So now it's time to go to the guideline. And this is a snapshot of part of the guideline decision tree that's in the reading that you were assigned in terms of the clinical practice guideline from IDSA. And I've added a few little graphics here to emphasize a few things. In this case, again, we're looking at taking ourselves through and trying to decide whether or not antibiotics are needed. And what kind of antibiotics. So we look at, of course, the signs and symptoms, and we think about our cases, and we look at symptoms that are persistent and not improving, and looking at a 10-day window. Now, in the book, they talk about 7 to 10 day, and 10 days is kind of the standard that you see in most guidelines. And so, that's one thing I really try to do with patient teaching is that really, I'd be happy to see you back in 10 days if you come in on day 2, which is fairly common, especially in the younger population. They feel sick, they feel miserable. But let's see you back in 10 days, and we will give you some symptomatic treatment. We'll talk about that in a minute. Again, severe, it's very severe symptoms for 3 or 4 days, or the worsening or double sickening, which we talked about earlier. And that situation maybe 3 or 4 days. Antibiotic resistance assessment is something we want to do at this point. You say, maybe we want to give antibiotics. Well, let's think about people who are very young or very old. Those children in daycare have high levels of antibiotic resistance. It's often from many treatments for otitis media, which is very common as well. Anyone who's had prior antibiotics in the past month, and that was our case C, prior hospitalization in the past 5 days, none of our people are there. Comorbidities and immunocompromised, like our diabetic patient, may be somebody that we want to look at. So we kind of figure out, are they going to have resistance? So we've decided that they have these symptoms, they do need treatment. We also want to treat them symptomatically, and then we have to go into the decision point about first-line versus second-line antimicrobial therapy. So before we get into the antimicrobial therapy, some thoughts, and you see it in your textbook, some great thoughts about symptomatic treatment. One of the things that I want to emphasize is the book talks about using nasal saline lavage, which is neti pot, or saline rinses, if you will. And this is different than just a spray of saline in the nose, which can be very helpful as well, just kind of makes the patient feel a little more comfortable. But the lavage actually kind of gets out all that crusty and thick discharge. It also has a soothing effect of applying warm fluid directly to the nasal passages and up towards the sinuses. What I will emphasize that the book does not is that if they're going to do homemade solutions and not just use a commercially prepared solution for the rinses, they must have sterile water. They must boil the water. I believe it's 10 minutes of boiling before you can render tap water sterile. Because remember that a lot of us have wells. Our water isn't necessarily sterile or fluorinated, and that we really have to be careful about that. So there have been cases reported in the literature of sinusitis actually caused by dirty water, and so it must be boiled. I can't say that enough. But that said, neti pots are a great solution. Some people hate them, a lot of people love them, and they really do work. And I treat all patients who are willing, who have any rhinosinusitis, whether or not I'm going to use antibiotics. I do treat them with this. There's also, certainly symptomatic treatment, which the book details very nicely in terms of antihistamines, the non-sedating ones being preferred, of course. And they talk a little bit about topical nasal corticosteroids, which have had varying reports in the literature in terms of efficacy. I do know that people do find some relief, particularly in chronic situations, of that kind of inflammatory situation with the nasal passages and the sinuses. We do use them for chronic disease. The problem with acute rhinosinusitis is that they really aren't effective until about a week or two in, so there's frustration on the part of the patient. I will sometimes advise patients to go ahead and use an over-the-counter decongestant spray in the nose with the severe caution that that should be a 3-day maximum only to avoid the rebound. It's hard for people to get away from those if they really are getting relief, and I've got to say that teaching about that is a bit of a challenge sometimes. But those are the thoughts before we think about antibiotic therapy or concurrent with antibiotic therapy. So now I'll let you open your Sanford guide and take a look to see if you have decided to administer or prescribe antibiotics, which of those antibiotics would you choose, and take a look at the first line and second line antibiotic therapy. Again, think back to what are the organisms that are causing this. They're very similar to the organisms of acute otitis media. And so we are looking at Strep pneumoniae. We're looking, of course, at virus, which we're not treating with the antibiotic, but we're looking at Strep pneumoniae, M. catarrhalis, and H. influenza. So these are, again, a gram mixed gram-negative and gram-positive. And when you look at the tables in the back of your Sanford guide, which give you your comparison of the spectra of the antibiotics, you'll see that the beta-lactams are a good first choice, although in adults we really need to add the clavulanate because there is varying mechanisms of resistance in any of these three major organisms. So first line is amoxicillin high dose with clavulanate. So you're looking at fairly high dose, and I'll let you look that up. In the second line antibiotics, which would be for people who are panallergic or who might have had resistance. And again, you've got two cases here where resistance and or a status of immune compromise may be present, that you might consider going to a second line therapy. Again, these are not without problems. Clarithromycin is a strong drug, has tons of interactions. We haven't listed any of the other medical conditions or medications these patients might be on, but consider that there's going to be a lot of interactions there and side effects. But if they're allergic, we need to consider any of those choices. I'll let you think about this a little bit. There is one case here which I would not treat with antibiotics, and I'll let you figure that out on your own. I'm sure you all can. So the rest of the algorithm that's from the guideline just takes us down through what happens next. And I have to tell you, a fair number of cases, and these are people who it's basically an acute on chronic situation where they really have an underlying chronic problem, whether it's their immune status or whether it's antibiotic resistance from multiple courses of antibiotic, or whether it's from something like an allergic situation underlying or a chemical situation underlying their sinusitis, that we really want to see improvement after 3 to 5 days. And this is important in your patient instructions, telling them to be patient for 3 to 5 days and see how we're doing. If they're worsening, of course, they're to return immediately or to call immediately, and we switch to a different antimicrobial. If they are even on either arm of whether they initially needed first or second line therapy, if they're improving, of course, we just have them complete 7 to 10 days of therapy. And depending on the antibiotic and the instructions in your Stanford guide or other resource. And then, of course, we can try to switch to a different antimicrobial class, and that's important. So you don't want to stay in the beta-lactams if they don't improve on the augmented, which is amoxicillin plus clavulanic. And if they're worsening, we really need to refer them if they're not getting better at this point. And so we give another 5 days. So it's really a 10-day window altogether. If they're not improving, they really have to go on. And that at that point is when imaging is going to be considered. Probably CT because you get the bone structures in there. MRI is not as helpful, although it can detect certain things. And that will be a decision point at the specialist level. And they might also do some cultures to see exactly what pathogens are going on, as described in your book. I already alluded to a couple of the complications that can happen with folks. Orbital cellulitis I would probably put at the top of the list because although it's unusual, it isn't as rare as the neurologic problems. And so that would be one to look for. It's pretty obvious on exam and certainly would not be something missed by you or the patient. And I do tell patients, you know, worsening means that you've got new symptoms. Something new or different has happened here. And that may be going on. While not a complication, I want to just emphasize that occasionally we can have concurrent dental abscesses with these cases. Happily, a dental abscess will respond to the same antimicrobials, and basically, if it was the root cause of things, pardon the pun, you do want to make sure that there is a dental referral if the patient also identifies that they have toothache and you can see obvious infection in the oral cavity. And of course, that's going to be part of your exam. But in terms of complications, again, the orbital cellulitis, the meningitis, which again the book talks about at some length, and you can look at what things might be going on. So I want you to think about and conjure in your head, based on your reading, what would be some of the red flags in your presentation of the patient as they tell you their story, or on your physical exam, which is where you may pick up some of the subtle signs of neurologic impairment. These next